Hello and happy finals week, everybody. We did it. We made it to the final week of critical care. As promised, I am going to make a few more videos to help us prepare for the final exam. So today I'm going to talk about spinal cord injury. Spinal cord injury, I feel, is fairly straightforward as far as understanding the level of injury and what is going to happen. So as we know, we have the cervical vertebrae, the thoracic vertebrae, and the lumbar, as well as the sacral. So if you think about where the injury happens and what is the result of that, we can pretty much assume that anything below the injury is going to have dysfunction. So for instance, a C4 injury is considered tetraplegia or quadriplegia, and that is complete paralysis below the neck. So we're automatically going to think respiratory because the lungs are below the neck. Obviously, there's other systems we have to consider as well, but when we follow the ABC priority, airway is going to be the priority. So C6 injury is partial paralysis, so as it would be anything below the injury, so the hands and arms and the lower body, with basically below the chest. And then an L1 injury is paraplegia below the waist, so that would be the legs. So one little trick I use to remember this that a friend taught me is C3, 4, 5, keep the diaphragm alive. So anything around that, you automatically want to think breathing. So like I mentioned with the respiratory system, above C4 is going to be a total loss of respiratory muscle function. So that is going to be extremely dangerous. Below the level of C4, diaphragmatic breathing is going to result in respiratory insufficiency. So with cervical or thoracic injuries, this is going to result in paralysis of the abdominal and intercostal muscles, which in turn will create an ineffective cough, which increases the risk for aspiration, atelectasis, or pneumonia. There's also an increased risk for neurogenic pulmonary edema with respiratory dysfunction due to spinal cord injury. This may increase during the first 48 hours, and a mechanical ventilation would be required most likely for this patient with increased pulmonary edema.
Your priority interventions will be number 1, immobilization. You will always want to stabilize this patient to prevent lateral rotation. So a hard cervical collar or a backboard. We will always log roll these patients as a unit, and maintaining airway is always the priority, as I mentioned, maintaining ventilation and breathing. So administer oxygen, provide ventilation support, chest physiotherapy, assisted or augmented coughing, tracheal suctioning, incentive spirometer, and or pain management will all assist these patients with their respiratory function.
The cardiovascular system is also affected with certain spinal cord injuries. Specifically, injuries above T6 lead to dysfunction of the sympathetic nervous system. This can lead to neurogenic shock. With neurogenic shock, the manifestations are going to include bradycardia, peripheral vasodilation, and hypotension. And if you think about that, anytime we have vasodilation, we are going to have hypotension because that blood vessel is dilated. It's like drinking a milkshake out of a larger straw. It's not going to have as much pressure. It's going to be easier to flow. So that peripheral vasodilation is going to cause hypotension. That hypotension results in relative hypovolemia, meaning it's going to appear as if there is less volume because of that increased capacity of the dilated veins, which in turn reduces the venous return and increases cardiac output. We are most concerned with the cardiovascular system with T6 or higher due to that dysfunction of the sympathetic nervous system. and which results in hypotension. Anytime we have significant hypotension, we have a risk for shock. So neurogenic shock is a sudden loss of sympathetic nervous system signals. And again, this results from T6 or higher. And you will see hypotension and bradycardia. And I mean severe hypotension and bradycardia. This is due to the disruption of autonomic pathways, which causes a loss of sympathetic tone, which results in that vasodilation, which equals a peripheral vasodilation, and venous pulling, which results in decreased cardiac output. I'll go into that a little bit more, but the treatment for this is often atropine. Side note, but you definitely just want to know that with anything T6 or higher, your risk for neurogenic shock should be the first thing your mind goes to. And when you think neurogenic shock, hypotension, bradycardia. You also have warm, dry skin with this type of shock. It is similar to spinal shock, so it's important to also understand the difference between the two. Neurogenic shock is an actual shock that, could potentially result in death for a patient. Spinal shock is a syndrome that is an immediate, temporary, so it's important to understand it's a temporary loss of total power and sensation and reflexes below the level of injury. It can last for days or weeks. They will have lost deep tendon reflexes and an absent sphincter control, which is also called the bulbocavernous reflex, and it's absent. And that's absence. The anal sphincter does not contract if it is spinal shock. With neurogenic shock, it's variable, but it could be there. So that's one difference. You will have flaccid paralysis below your level of injury and a complete loss of motor function with spinal shock. The peripheral neurons become temporarily unresponsive to brain stimulation. So again, this is just a temporary disruption and loss of power and sensation and reflexes below a level of injury, where neurogenic shock is more related to the sympathetic nervous system. So it is going to be more related to blood pressure and, the vital signs that we need to keep a very close watch on. Due to this interruption with the cardiovascular system, there's always that risk for bradycardia. That risk for bradycardia can lead to cardiac arrest, chronic low blood pressure with postural hypotension, and due to the fact that blood is pooling and that decreased venous return, we will automatically have a risk for DVTs. Anytime that blood is not flowing like it should be, that risk for DVTs is also there. So keep that in mind. The GI system is also affected with spinal cord injury, and that's due to a decrease in that GI motor activity or decrease in the bowel movement. Often results in paralytic ileus, which means the paralyzed ileus. So the GI system just really isn't working for these patients, especially in the beginning. So nasogastric suctioning will be required for these patients with paralytic ileus to help decrease that pressure. Gastric emptying may be delayed for these patients, as well as excessive release of hydrochloric acid, which may result in stress ulcers. So you want to be aware of this. Maybe prophylactic treatment for ulcers would be necessary for these patients. Dysphagia may be present, and intra-abdominal bleeding due to those ulcers, which may be difficult to diagnose. So there's a lot of risk factors associated with the GI system that we definitely want to keep an eye on with these patients. We also want to get them on a bowel management program, kind of like the bladder. Initially, these patients will have the neurogenic bladder, and so you want to then start them on the bowel program, and that's during the acute care. There will be daily rectal stimulation, which would be a suppository or enema to help with stimulating the bowels and releasing of stool. There also may be necessary to do a digital stimulation or evacuation of feces, since the muscles just really aren't working for these patients. It is also important to have adequate fluid and fiber intake for these patients, and if possible, to increase activity and exercise, even if it's passive range of motion. The skin is also going to be an important system to look at due to the potential of skin breakdown. These patients are not moving very much, as well as the fact that blood is not flowing as it should due to that poor venous return we spoke about earlier. So the potential for skin breakdown is high. We want to keep an eye on these patients as far as that go. They also have an inability to control their temperature internally if they have that interruption of the SNS. And this will also decrease their ability to sweat or shiver below the level of injury. So these are more common with those high cervical injuries, but that inability to control the temperature is important to monitor for these patients. So we'll have to make sure to keep the environment at a temperature that is going to regulate the patient, because they will be taking all of their temperature from the outside. We need to consider metabolic needs for these patients. As mentioned before, an NG suction is likely indicated, which can result in metabolic alkalosis. Much like vomiting, that NG suction is going to be removing some of those acidic juices, which will cause that alkalosis. So due to that, you're going to want to monitor these patients' electrolytes, especially potassium and sodium. You also increase nutritional needs for these patients. So when we think about nutritional needs, we want to nutritional support to be focused on caloric and nitrogen needs. So that means high calorie, high protein. Prevent skin breakdown. We're going to reduce infection, and we are going to try to decrease muscle atrophy by providing these patients with a high caloric, high protein diet. We do usually start nutrition within 72 hours, and it can include individual solutions or additives and possible TPN. If there's a paralytic ileus, the NG tube will be indicated, as mentioned before, and we are going to continue to monitor these patients' fluid and electrolytes. We touched on this a little bit, but there are peripheral vascular problems like those venous thrombosis or DVTs, which could also result in a pulmonary embolism. This is actually the leading cause of death for these patients because it may be difficult to detect DVTs, and therefore they can easily travel to the lungs. And these patients also don't have great venous return, which again results in that thicker pooling of blood and can cause those DVTs. We want to keep these patients on a low molecular weight heparin to prevent it. They will most likely also be on vasopressors to maintain their arterial pressure above 90. And there are risks for complications associated with that. There's also altered drug metabolism. So this is important to understand with these patients because of all of the factors that I've mentioned so far in all the different systems. The altered drug metabolism can increase the risk for interactions. So much like an elderly patient, you want to keep an eye on that. Pain is unfortunately very common, and these patients are usually in a good amount of pain, so we want to make sure to manage that for them. There's different types of pain. There's nociceptive pain, which is musculoskeletal pain, which feels like a dull aching, which worsens with movement. There's also visceral pain, which typically happens in the thorax, abdomen, or pelvis, which is a dull, tender cramping. Neuropathic pain, which is always located below the level of injury. This is that phantom pain where they still feel the injury below it. So it's a hot, burning, tingling, pins, needles, or a cold shooting. They are extremely sensitive to stimuli. However, with time, this type of pain does decrease. Initially, it is very painful. So pain management for these patients would include on the type of pain, but a few options would be anti-inflammatory or opiates, gabapentin, or Lyrica. You would also want to teach these patients their triggers to understand what their triggers are and how to relax through those triggers. So to reiterate, temperature control is important for these patients. They do not have vasoconstriction, piloerection, heat loss, or perspiration below their level of injury. So their temp control is from the external environment. You want to make sure to continually monitor the environment as well as the patient's temperature.
With the urinary system, neurogenic bladder is the most important thing to remember. There are different phases. With the acute phase, there's going to be urinary retention. With the post-acute phase, you might have hyperirritability. So in the acute phase, you are likely going to be doing an indwelling catheter. You will make sure to maintain aseptic technique with that indwelling catheter. And then with the, you will start the patient on an intermittent catheterization program 4 to 6 times daily, and you will want to continually monitor them for a UTI. The reason for this is to prevent autonomic dysreflexia due to the bladder being full. So you want to make sure to train this patient's bladder, or at least drain it so that it doesn't become overdistended and irritate the patient. There are some drug therapies that could be indicated depending on which stage or phase that the patient is in. So it could be anticholinergics, adrenergic blockers, antispasmodics, and again, that bladder reflex training. One of the main complications of spinal cord injury is autonomic dysreflexia, or hyperreflexia, which is an exaggerated reflex response by the autonomic nervous system, which causes a massive uncompensated cardiovascular reaction, which is mediated by the sympathetic nervous system. So what this means is that the SNS, or the fight or flight, is responding to an irritating stimuli that the parasympathetic, the rest or digest nervous system cannot counteract its response. So that means there's a disconnect between the SNS and the CNS, which is considered a medical emergency. This is usually due to an injury T6 or higher. They are most at risk for this autonomic dysreflexia due to that break in the SNS and CNS transmission.
To fully understand this, we have to kind of go back to the basics of the autonomic nervous system. It is broken into 2 parts, the SNS and the PNS. The sympathetic, or SNS, and is responsible for vasoconstriction, or increasing blood pressures. It also stimulates sweat glands. It causes bronchodilation. It increases the heart rate. It dilates pupils. So when I think of sympathetic, I think of everything getting bigger, higher, or hotter. So basically, we're going to sweat and everything is going to increase. That is your fight and flight response. So that makes sense. If you've got to get up and go, you need your heart running, you need everything bigger and better. The PNS, however, opposes the SNS, meaning it does the opposite. It causes vasodilation, which decreases blood pressure. So like that analogy I gave earlier with the milkshake, when we have a small straw, that is vasoconstriction, the pressure inside that straw is going to be high. When we have a large straw, that is vasodilation, and the blood pressure, or the pressure in that straw, will be low. So vasodilation causes low blood pressure. I think that's a concept a lot of people struggle with, so that straw analogy really helps me. With the parasympathetic, we also get the decreased heart rate, bronchorestriction, and constricted pupils. So everything is going to get smaller, lower. You are going to rest and digest with the PNS. So this is just, again, a review to kind of remind you what we're talking about when I say there is a break between these 2 systems. What does that mean? Well, these 2 systems are responsible for maintaining homeostasis by opposing each other. So if the blood pressure is too high, then the parasympathetic kicks in, and vice versa. If that is broken, we're going to have a really hard time maintaining homeostasis. So the pathophysiology behind autonomic dysreflexia is that an irritating stimulus, either a full bladder, it could be that they have to have a bowel movement, are often causes. We'll talk more about causes later, but that irritating stimulus will exaggerate the sympathetic reflex response. And that will cause the vasoconstriction of the vessels below the injury, which will increase blood pressure. Once that blood pressure is increased, the baroreceptors sense that increase, and they try to activate the parasympathetic system, which causes vasodilation, or flushing, but only above the injury because it's not working below the injury. This will decrease the heart rate and that compensation is broken. So the method is not going to work because of that vasoconstriction below the injury.
Which means that the blood pressure is just going to continue to respond to the SNS and not the PNS.
Therefore, the manifestations are going to be hypertension. The blood pressure is going to continue to stay high because that PNS cannot kick in and decrease it. So you also have bradycardia and a throbbing headache. That's important to remember, and diaphoresis above the injury. So that throbbing headache is often the first sign that this person needs to use the restroom. They can also experience piloerection or the goosebumps and flushing above the injury due to that vasodilation. There could be blurred vision or spots in their visual field. They could have nasal congestion, anxiety, and also may experience nausea. So when you think of this autonomic dysreflexia, you want to think of the causes being the 3 B's, and that could be bladder, bowel, or breakdown. So remember, it's an irritating stimulus. It's something that's saying, hey, I'm irritated, I need to relieve this. So it's either going to be that they have to use the restroom, either go number 1 or 2, or their skin is breaking down, their clothes might be too tight. These are all things that your brain would try to tell you to fix, but it can't. So the manifestations are going to be different in these patients. The nursing interventions are going to be prevent, detect, act. So it's most important to recognize this very quickly due to the fact that it is a medical emergency. If you miss the early signs of this, it could be too late. So the first thing we want to do is elevate the head of the bed 30 degrees. That's the quickest intervention we can do, and notify the MD immediately. It is an emergency. Then we will assess and remove the cause. So that could either be a catheter to remove the urine. If they do have a catheter, is it draining? Is it kinked? If they have a distended bladder, you could straight cath them to remove that urine. You would remove impacted stool if it's present. You would remove constrictive clothing or tight shoes. And then you would obviously want to monitor and treat that blood pressure because the blood pressure is going to be what is so dangerous. So that is the basics of autonomic dysreflexia with these patients. And it is important, again, to monitor for the 3 B's for these patients, which is why you would keep them on the bowel and bladder schedule as well to help reduce the risk for autonomic dysreflexia and help the patients be aware of the early manifestations as well as being able to evaluate them as a nurse so you can prevent, detect, and act quickly. Again, this is a medical emergency that needs to be addressed immediately.
Thank you all so much for watching. I will try to make a few more videos to help myself prepare as well as hopefully help you all. And I wish you all the best of luck on your finals and a big fat A.